Very good morning to everyone present here. And good morning, Dr. Punita ma'am. Good morning, Dr. Arun. Good morning, Dr. Shaleen and all other participants. So this is our 11th online classes under banner of UP chapter AORI. So for this moderation, I would like to introduce Dr. Arun Verma. He's the principal consultant at Max Super Specialty Hospital, Papadganj and Vaishali. Dr. Arun Verma, it is over to you.
Thank you, ma'am. Today, the topic is very interesting. I think every student want to know what are the landmark trial, and I think no one best can teach us. Dr. Punita Lal, who is leading the SCPGI department, and now, I think everyone knows. Without wasting time, over to you, ma'am, and thank you, ARI, for initiating such a beautiful concept. Thank you. Yeah, over to ma'am.
Thank you, Arun. Good morning, everyone. I can't make out who all are there, but yes, good morning, Shaleen also. And thank you, Arun, again for giving those kind words of introduction, but I'm not leading the show. Our Up-Aroi president, Dr. Shaleen, is leading the show. This is a very nice opportunity for me to thank Up-Aroi, one, to take this wonderful initiative. I mean, it is neither easy to collate so many, but the focus on education of our students, especially of the state of Uttar Pradesh, is a wonderful thing. And also, thank you for giving me the opportunity to be amidst you all and talk about something that maybe we've been doing for some time. So before I start, let me just say, why do we need to understand these landmark trials? What are these landmark trials? Well, these are trials which have been game changers. They've helped us decide regarding the decision making for the patient. What is the optimal decision making for an individual patient? So they are very important to us on a day-to-day basis, more than just academics or research. They help us in defining what we need to do for the patient. Now, there are hundreds of trials, landmark trials, so-called landmark trials. I cannot deal with those many. I will be talking about quite a few. Those are the trials which have either helped us in deciding for our patients, or we've kind of dissected them out in journal club, or while doing a thesis or some kind of a research project. So we have seen the evolution of those trials and how it helped us navigate and understand the nuances better. And I will try to take them in a stepwise fashion for the sake of students. And of course, I have no conflict of interest. So to start off with, let's begin that it's an age-old thing that surgery has been the gold standard in head neck cancers and has given us the best results. So should be conducted whenever possible, but it comes at a price. Radiotherapy, on the other hand, is a very effective local regional treatment, and it does not yield results as good as what surgery does. And of course, there's this issue of treatment-related morbidity, which we need to factor in. And so clearly for us as radiation oncologists, there is a lot of scope for improvement, and which is what we have done over a period of time. So in the last, I think 3 or 4 decades, a lot of work has happened in multiple directions in head neck cancers. People have worked on chemotherapy trials, the fractionation they've tried to optimize. Technology, of course, has been working over time, and then there is palliation, and surgeons have been working. So some of the trials, I would say, came with loud announcements, and we were waiting for them. And once they came and we dissected out and we saw and we realized that they did not turn out meet the expectations, or they did not find a birth in the decision making of the patient. That also helped us because it tells us what not to do. And then there were some trials which came stealthily. They walked in from the back door, and they are there they are there to stay. So let us look into some of them. For instance, if we talk about chemotherapy, which I know is a part of our therapeutic armamentarium, and we all heavily bank upon it, because radiation, you can go up to a point, and beyond 70 Gray, we cannot. So we need to look into other facets which can improve our results. So addition of chemotherapy has been tried in various ways, including neoadjuvant to start off with. Then we came up with concurrent, post-op CTRT, and sequential. Then we also looked into whether it is like, should we give once a week, should we give 3 weekly schedule. So all this, time permitting, I will discuss. Because this topic is lengthy, I may be, the organizers are welcome to tell me to stop. I can take it later, I can redo it again, or we'll just stop if it's not of common interest. So let's talk about head and neck cancers. Largely can be divided into early and advanced, and advanced usually is which comes to us as radiation oncology. Those can be divided into resectable group and unresectable. Resectables inevitably biologically tend to do better than unresectable. Now, resectable groups, the endpoint is that, okay, we'll be able to give you good results, but can we preserve the organ, which is what we can have an edge over the surgeons. So first things first, we started off in our field of oncology with the use of addition of induction chemotherapy in these resectable cohort of patients. The story began with Veterans Affairs Administration trial, which was started in the 80s and was published in 1991. And what they said was that, okay, total laryngectomy gives us satisfactory results, but it takes away the voice of the patient. Can we preserve the voice? How? So they decided to randomize their resectable larynx, which were belonging to stage 3, stage 4. They were moderate volume intermediate group. And they said, okay, we'll compare it with neoadjuvant chemotherapy followed by radiotherapy. We'll give them 2 to 3 cycles of cisplatin 5-FU radiotherapy, chemotherapy, and see the response. And then what they did was, their study design was such that they planned that, okay, if they respond, they will go ahead with radiation, which is the non-surgical loco-regional treatment, and we will try to preserve the larynx. If they don't, then no point, go ahead with total laryngectomy again. So what did this observe or report? They said that they could preserve 2/3 of the larynx at 2 years, and it became 1/3 larynx were preserved at 5 years. What they also learned in this trial was that primary site is best taken care of by surgery. Regional nodes, if you combine both treatment, it is the best possible. And distant metastasis, second primary, if you give systemic agents, then the distant metastasis rate can decrease. So this is what was the learning point. What were the lessons that this trial taught us? That, well, because an effective backup strategy was existing in the form of total laryngectomy, survivals were no different. The moment the patient failed, the total laryngectomy could be done. So the patient survived. So survivals were no different, and the overall survival remained around 35% in both the arms. What this trial managed to answer for us was that it identified the subset through chemotherapy that is likely to respond with radiation and have a preserved larynx. What it didn't answer was, people started asking them question, the veterans group, that, okay, look here, you gave neoadjuvant chemotherapy and then you gave radiotherapy. Why not give radiotherapy? That's a non-surgical treatment where you can preserve the organ and treat accordingly. So that was the question that came from this very path-making trial. So as happens in science, you answer one question and then you generate a hypothesis. Okay, why didn't we do that? Why can't we do it better? So this was the question that was that arose from this trial, and this paved the way for the next trial, that was RTOG 9111. which was another laryngeal preservation trial. In this trial, the study design was formulated taking the same similar cohort of patients. That means intermediate risk, moderate volume, stage 3, stage 4, resectable larynx. No different from veterans. So they said, okay, let's compare neoadjuvant chemotherapy followed by radiotherapy with just radiotherapy. But what had happened by that time, this trial was designed in 1991, and by which time concurrent chemotherapy along with radiotherapy was taking center stage. It was gaining popularity, and it was very difficult for the trialists to not include concurrent CTRT as the third arm. So that got included as a third arm. They looked at various disease-related endpoints, and they saw that the main thing was organ preservation, and that actually was best with concurrent CTRT as compared to the other two arms. The moment you added systemic chemotherapy in whatever sequence, in whatever timing, and whatever dosage, the distant metastasis rate decreased as compared to just loco-regional treatment in the form of radiotherapy. Because there was an effective salvage strategy available in the form of total laryngectomy, whoever failed went ahead and got a laryngectomy done. So the survivals never changed. They were hovering around 55% in all the three arms. This is what they told us in 2003. 10 years later, they presented their long-term results. And something very interesting was happening. Something was happening at around 5 years, where the survival curves, if you see, started, which were so close, the blue, gray, and the yellow were close together. They started to separate out. And something was happening in favor of neoadjuvant chemotherapy. Actually, it was more in disfavor of the yellow line, which was concurrent chemoradiotherapy. There were more deaths. And that was getting reflected in the long-term overall survival. Then they looked at each of these deaths, and they found that it was not cancer-related deaths that were happening, but it was the non-cancer-related deaths, like, for instance, aspirations and all, which were the real cause of the fall in the survival curve in CRT arm. So the learning lesson in 2013 was that CTRT, concurrent CTRT is good, but maybe not as good as we thought. There's something that needs to be looked at. So there was food for thought for all of us, that look at your patients, select your patients well. Let's go back, because the story is not complete unless we talk about the meta-analysis, the mother of all meta-analysis, that is the McKinsey group, which conducted this meta-analysis, which had multiple meta-analysis as a part of its analysis. And it was led by Pinon et al. And they looked into the laryngeal preservation trial. So although veterans showed that neoadjuvant was working, was somewhat effective in laryngeal preservation, but the other trials that were being carried out in those times did not help in when the pool data was analyzed, and they said that laryngeal preservation with neoadjuvant remains investigational if you are talking about all patients. Probably in select group of patients based on veterans trial and on RTOG 9111, we can say that it is beneficial in moderate volume, stage 3, stage 4, resectable larynx, where there is no cartilage invasion, where there is no base of tongue involvement. That's where it is working. Let's go to unresectable disease, which is a large cohort of patients which comes to our OPD day in and day out. What is addition of chemotherapy doing? Here, we have an edge. We at least want to have an edge over the surgeons, because they cannot operate, and we probably, by adding chemotherapy, may give some survival benefit to these patients. Let's look at induction chemotherapy, because we always started with that. And there were hosts of trials, small, big, randomized, non-randomized trials that were done during the 80s. And generally it was found that it was the Pinon meta-analysis showed that it was, they were not doing, they were not giving a significant difference with the induction chemotherapy. The same meta-analysis, when later updated their results, showed that the magnitude of benefit was about 2 to 2.4% with the addition of induction chemotherapy. And we will talk about this 2% figure at a later date in another context. Just keep it in mind. So that's the magnitude of benefit, and that is insignificant. And that probably is getting obtained because you are reducing the risk of distant metastasis. So there is a potential for improving disease outcome is what was felt at that point in time, because you're decreasing distant metastasis, but it's coming at cost and toxicity. And they also felt that this is important from our point of view, because we sometimes continue to give induction chemotherapy for longer period of time. So the understanding at that point became that give 2 cycles, don't delay the primary treatment. It is the primary treatment which makes all the difference. By delaying, you're probably not benefiting the patient, and you're adding to the cost and toxicity of the patient for the patient. Let's come to concurrent chemotherapy. This was started somewhere in early 80s. So RTOG actually looked into the use of cisplatin chemotherapy given concurrently at 3 weekly intervals in a pilot study, and that yielded promising result. That then became the basis of use of concurrent 3 weekly cisplatin chemotherapy in lot of randomized trials, and consistently meta-analysis after meta-analysis, we got the results that on a long-term basis, we could say that it was giving a benefit of about 6 to 8% when we use cisplatin in this fashion at about 5 years. We also noticed through the meta-analysis that the benefit started to decrease with age as the age advances beyond 70 gray, especially the cutoff or the watershed line was around 70 gray. Why? Because patients become frail, they lose body fat, weight, the physiology changes, they develop comorbidities. And what happens is that because the physiology changes, their absorption of the drug, assimilation, elimination, metabolism, everything becomes slower. So instead of getting benefit, probably you get more side effects, and you sometimes land up in losing patients also. So that was a very important learning point. And in our country and in our state more so, I would like to reiterate here, where before Aadhaar card, things were so different. Age was like a 70-year-old would come written as 45-year-old. So use your common sense. Look at how the patient is he looking older? Is he frail? Those become very important decision-making points from our point of view. Then comes the what else we learned, that concurrent chemoradiotherapy also had a site predilection. Some sites like oral cavity oropharynx benefited more than larynx hypopharynx. So those were the learning points. Once concurrent chemotherapy was saddled into the driver's seat, it got established. The proponents of neoadjuvant came back again. They had renewed interest. They said that, okay, we now have another drug, that is the taxane. So let's give a triplet, 3 drug. Apart from cisplatin 5FU, let's try adding taxane to neoadjuvant part of the treatment and CT-RT instead of RT alone. And their hypothesis was that we can probably attain maximum benefit if we use CT-RT, because that will give us better loco-regional control. We've established that. We use good doses of a triplet regime in induction form, and we will take care of distant metastasis more than a doublet. So that was the genesis of the most quoted TAX 323 and 324. 323 and 324 trial. In both these trials, they compared a triplet regime of induction chemotherapy with a doublet regime of induction chemotherapy, and then went on to give some form of intensive locoregional treatment, either in the form of concurrent CTRT or altered fractionated CTRT. So they got a survival benefit to an extent. And both these trials did the similar kind of protocols were adopted. To put them in the center stage, a meta-analysis was also done, which showed that TAX, the triplet was superior to doublet. It gave survival benefit. It lowered the distant failure rate, but it was toxic. So the proponents of TAX 323 and 324 said that it should be the new standard of care. Why? Because TPF is superior. Doublet is better, especially when you added taxane, and it should be looked upon as the optimal induction chemotherapy regime. But there was heavy criticism to these trials, which we must take into account. And that is, they failed to answer the fundamental question, and that is, what is the relative efficacy of induction chemotherapy? They did not address that. They said triplet is better than doublet. But let us first see whether induction is better than when you are already giving CTRT, then does adding induction help? So that was not addressed. Secondly, their loco-regional part of the treatment, that is when they were giving concurrent CTRT, or they said it was single intensification. But what was the intensification? They used carboplatin instead of cisplatin. So that is not standard of care as of now. Then they used, or the 323 used altered fractionation. Very promising, but still not the standard of care. So that was the other thing. Then they said that they underplayed the patient sickness part of it with the main treatment. The patients were too sick most of the times. The patients, they lost some patients. The patients, the compliance was only to the tune of 50% in most studies. So although they were showing some survival benefit, but it was coming at a cost. They did not talk much about the supportive measures they had to adopt, like growth factors and everything. Then hospitalizations. So these are things that when we adopt from the Western world regimes like this, we need to look into it with a fine comb, whether they can really benefit, not just in terms of giving better control at the local or the nodal site, but also how much cost, toxicity it entails. So since they did not address these fundamental question of the importance of impact of induction chemotherapy to CTRT, this was taken upon by the DECIDE trial and Paradigm, 2 trials, which answered this question for us. By this time, the interest had waned in people, and so there were accruals in both these trials were slow. They had to close these trials and they were underpowered. But still, what they managed to tell us was that if you give CTRT, whether or not you added induction chemotherapy, survival figures were similar. They were no different, but you gave adverse events to them. The toxicity was higher. So both these trials were that way similar. But what they managed to tell us was that not only were induction chemotherapy didn't do wonders beyond concurrent CTRT, but addition of another cycle of chemotherapy was only adding to toxicity, and not no survival benefit was attained. But what they also told, if you look at the DECIDE trial, they said that probably there is a group which is N2, N3, N2C, N3, where, or the lower neck nodes when they are heavily involved, then that is where distant failures are higher. Because we all know head neck is a loco-regional treatment. Failures below clavicle are limited and less, but when the disease occurs in nodes in the lower region, third, fourth, fifth, and supraclavicular, that's when below the clavicle disease is seen. And so if we give this kind of regime at that point in time, distant failures would be less. So a subset was generated for the future trials. So induction chemotherapy has been there with us for 3 or 4 decades now, but it's still not made a major dent. And we'll see how people have given that explanation. It's probably still remains a hype. We know that it works on distant metastasis, at least theoretically speaking. So the distant metastasis rate in head and neck cancer is about 10 to 15%. If we give strong and optimal doses of chemotherapy, probably we can bring down the metastasis rate from by half, decrease it by half. So let us say we are now going to give an advantage of 5% in patients whose distant metastasis rate probability was 10%, it will come down to 5%. Now, additionally, when you give chemotherapy in the doses that you would, the trials, best of trials have given a mortality figure of about 2 to 3%. So you bring that down, 5 minus 2 to 3%. So you can expect a benefit of 2 or 3% with the induction chemotherapy. I just want you to recall that I did tell you to remember that there is a significant benefit, non-significant benefit of 2.4%. The meta-analysis showed us then nothing changed. We can expect a benefit of about 2 to 3%. We still continue to use induction chemotherapy in our country. It's very topical, but very prevalent. Why? Because of 2 reasons. One is that it helps us in downsizing. Our tumors are inevitably bigger, larger nodes. You start with N3 node or large N2 matted mass, and you treat it, and the tumor melts, and the cast becomes loose, and we lose the gains are offset. Gains of good radiotherapy are offset. So somewhere it helps us in that also. It gives since adaptive radiotherapy cannot be a routine option in our setup, then this probably does what adaptive radiotherapy does. One possibility. The other, which is a major thing that it does to us, is it takes care of the logistics. Let us remember that we have about 800 to 900 machines in our country, less than 1,000 in a vast country like ours, and a huge cancer burden population. So waiting periods are inevitable. It is to take care of these waiting times that we are buying time at a cost and with toxicity. This has also been shown very elegantly in the audit by the Royal Marsden Group. I won't go much into detail, but they had once upon a time, every department has some lull periods. They will have machines which are aging, waxing, waning, not working, and then the machines come. So there was a time when they did not have so many machines, and they gave a doublet regime in conservative doses, 2 cycles, and then without any delay, they gave primary treatment. They found that the toxicity was tolerated, and it was a doable protocol with promising results, which is what I just wanted to bring to light, that this is what most of our country, especially our state, has been doing in this scenario. Let's go to post-op chemoradiotherapy, where we have again found that chemotherapy works in certain situations. 2 trials, one from Europe, another one from America, have both shown that if you operate upon stage 3, stage 4 head and neck cancers, they need adjuvant treatment in the form of radiation. Some of these have some adverse features, which if you add chemotherapy to it, helps. So the trial from Europe led by Jacques Bernier, that showed that there was survival benefit in the patient that they included in their trial with the addition of chemotherapy to post-op radiotherapy. The American trial had similar sort of patients, but different inclusion criteria, and they found that local regional control was very much better, but that did not translate into overall survival at the time of reporting. And they said that possibly it is to do with the kind of inclusion criteria that they had adopted. They also reported higher adverse events when you added chemotherapy to radiotherapy in post-op setting, and something that to be mindful of. Now, because we realized that chemotherapy, when added to radiotherapy in post-operative setting, is working, but we didn't know where it is working. So they pooled the data of both the European EORTC trial and RTOG trial and showed us that it is, and drew a Venn diagram, a very simple Venn diagram, which says that if there is margin positivity or extracapsular extension of the nodes, then you must give. It helps, but give it in fit patients, of course. But what happens if there are other high risk, other adverse features present? Then you may look into these features. If there are multiple of them, then as a physician, you can take a judgment call of giving chemotherapy or not, depending upon your patient's performance status. But resected margin positivity, not close margin, mind you, and ECE positivity were two factors which categorically came out that it helps to give chemotherapy. Next question, or rather last question in chemotherapy section, was that most of the evidence we were deriving from 3 weekly regimes which were adopted in the West. But across our country, at least, and most countries in the low middle income area, adopted the weekly schedule, and we were very happy because patients complied. It was less toxic, and things were in our control. So whether we should give 3 weekly or weekly, Tata Hospital has tried to provide an answer to this by comparing a 3 weekly regime with weekly regime in a single center phase 3 non-inferiority trial in 300 patients. They found that local regional controls improved with 3 weekly regime. Their population was mostly post-operative oral cavities, but they also report severe toxicity and much greater hospitalization with 3 weekly as compared to weekly regime. And this hospitalization is over and above of the hospitalization you would do routinely for chemotherapy. The other thing that they were criticized for was, well, they as a routine were giving 30 milligram per meter square and in weekly fashion. By now, our understanding is that it is the cumulative dose of chemotherapy. We can't increase the dose of radiotherapy, so we give chemotherapy. If the cumulative dose of chemotherapy is more than 200 milligram per meter square, somewhere it helps radiotherapy and has a synergistic activity. If it is less, then it is not. So if we are giving 6 weeks of radiotherapy and you give 30 milligram per meter square, you are around 180 milligram per meter square, and that probably is not adding to benefit. So the learning point is that if you are giving weekly, at least give 40 milligram per meter square and or above, and then that might benefit. So the jury is out, and we still need to look for. So if I have to wind up this section, I would say that yes, concurrent chemotherapy, radiotherapy is the standard of care in locally advanced cancer. Neoadjuvant is a non-significant modality. Post-op high-risk situation, yes, adding chemotherapy has worked. Weekly versus 3 weekly, the debate exists. But we still have to be mindful of the toxicities that we may give to our patients. And so we have to choose our patients well. Just like chemotherapy, the evolution was happening in fractionation story also. Fractionation started when Cotard gave us fractionation, but somewhere in 70s and 80s, people started working based on radiobiological knowledge or understanding of working on hyperfractionation, which worked on the differential that one could create between the difference in radiosensitivity between the normal, early reacting normal tissue, late reacting normal tissue, and the tumor tissue. Acceleration on the other hand, was backed by the radiobiological phenomenon that you can inhibit tumor cell repopulation by taking care of the overall treatment time. And there were many such acceleration schedules that were floating across the globe: concomitant boost, 6 fractions, chart, care, and so on and so forth. And then people became bolder and tried to see if altered fractionation, if it is combined with the chemotherapy, so it is a double intensification, does it have further synergism? So this was seen. Like I said, it was happening, hyperfractionation was happening in the 70s and 80s, and it was showing some benefit. Europe was practicing, mainland Europe was practicing hyperfractionation. They were convinced that it is working. In America, there were 3 clash of titans happening. In Florida, people said it is hyperfractionation which is working, and so they were researching on that. In Massachusetts General Hospital, C.C. Wong and his group felt that it is acceleration in a split fashion, acceleration with a gap, that seems to be working, and they were working on that. MD Anderson, what it was working was on concomitant boost schedule. Some part you give as single fraction a day, and then the last part where you can actually take care of the accelerated repopulation, you give twice a day and consolidate your gains. So since that answer had to be obtained, RTOG started a trial where they compared these 3 altered fractionation with standard fractionation, and they found that it's not the split course which is working. Hyperfractionation and acceleration, they both have show improvement in local regional control, possibly in overall survival also. They presented their results quite early at 2 years, when the late toxicity would not have occurred. And so the debate internally continued in their minds, although it set the stage for concomitant boost to be the standard of care in the United States of America. And most trials were then adopting that as their control arm and experimenting. Finally, there were a lot of conjectures, and they had to release the final results about a decade later, in 2014, or more than a decade. And they said that split course is not working. Hyperfractionation is actually superior. Accelerated fractionation with concomitant boost is also giving significant overall survival benefit. But this time they had underplayed the late toxicity at that point in time, but now that was emerging and they could not ignore it any further. So we felt that concomitant boost, while it works, but it comes at a cost of late toxicity. Of course, their plea this time was logistics. To do 2 fractions is very difficult. We all in India know that. But if you do most of your treatment as 1 fraction and the last part as 2 fraction, it is probably more doable. While America was jostling with these kind of fractionation, the think tank sitting in Denmark, Scandinavian country, they came up with a very simple, elegant, and with robust radiobiological backing, trial design, which says you give 2 grays. We are used to 2 grays per fraction. Give 2 grays per fraction every day. Don't give more. And instead of giving 5 treatments in a week, you give 6 treatments in a week. So they looked into this in the Dahanka 6 and 7 trial, and they saw that it was really working in terms of local regional control. You decrease the overall treatment time by 1 week, which is known as modest acceleration, and you decrease the overall, you improve the local control the jump is by 10%. Seeing that became the standard of care in Denmark. Of course, they gave it with radiosensitizer nimorozole, which the availability of which is very limited, and so it could not be tried in other countries. IAEA looked into this trial That trial was headed by Jens Overgaard, and at that time IAEA president was Jens Overgaard, and he said, if we could do it in Denmark, why can't we do it in resource-constrained conditions in low and middle-income countries like, for instance, all the Asian and African countries, and India also participated in this. TMH and AIMS were participants, and they said, let's try it in their cohort of patients. So, sorry. Okay, so while the study design was similar, but yes.
Yeah, ma'am. Yeah. Yes. Please go ahead, ma'am. Yeah.
Okay, so you can tell me when to stop. I mean, there's no problem. So while the study design was similar in this IAEA trial, but they allowed so many other things. Our tumors are inevitably bigger. So they allowed more T3, T4s as compared to the Dhankar trial. They allowed nodes, more nodes were positive, bigger nodes were allowed. Oral cavity is our problem, not there. So they had 5% oral cavity, we had 25% oral cavity in this patient. And additionally, they tried 2D planning and cobalt-60. So let us see whether this kind of trial is applicable and beneficial for the garden variety of patients in our setup. Interestingly, they got exactly, again, more than 10% improvement in locoregional controls, especially at the primary. What they observed, and they surmised was that this kind of fractionation was really working at the primary site, not so much at the nodal site. They also saw that that toxicity was so acceptable, it was not greater. The beauty of this trial was you did not require any additional resources. We in India work 6 days a week. So instead of treating 5 days in a week and giving 9 or 10 gray per week, we can give Monday to Saturday and give 12 gray per week. That's it. So it is worth looking into this trial. That is what they felt. While Denmark was doing that, Mount Vernon in United Kingdom was looking into another radiobiologically sound trial design, and that was the continuous hyperfractionated accelerated radiotherapy trial. This was being practiced in head, neck, and in lung tumors in their trial setting. So what they did was they gave 1.5 grays 3 times a day, morning, afternoon, and night, all 8 hours apart. This they gave continuously for 12 days, starting on Monday, one Monday, and finishing on Friday. There were no weekend offs. It was continuous. They did another thing to decrease the late toxicity. They brought down they gave smaller than conventional doses, and to decrease the acute toxicity, they brought down the total dose also from 70 gray equivalent to 54 gray. Interestingly, with 54 gray, just see the curves are identical. There was no difference in overall survival. That was the impact of this trial. Adverse effects were no different. So they felt it could be given in poor tolerance patients. A very doable and very lucrative option, because if you can treat one patient in 12 days, then you can treat 3 patients in those 7 weeks that you would treat one patient. But it had huge logistic issues. Patient compliance in terms of you had to hospitalize them. The night fraction was a problem for the patient. Getting technologists to treat in the night, getting technologists to treat over the weekend, huge issues. That's why this trial, although it's given benefit, especially in lung and to the tune what concurrent chemotherapy could give, it's given that kind of benefit, but it did not have wider applicability because of the logistics. It's probably not possible in a country like ours. So there were lots of meta-analysis that happened trying to study the fractionation story and complete it. Boris came up with the earlier meta-analysis, which compared the hyperfractionation with accelerated fractionation. And they said collectively altered fractionation does help the survival, gives survival benefit. But amongst all, hyperfractionation probably gives the best benefit. And you can expect good tumor control in young and fit patients. So that is what this thing was. Then people said, okay, altered fractionation is somewhat working, but how is it? Can we look at it alongside with chemotherapy, concurrent chemotherapy? So the March meta-analysis came up in 2017 that said that hyperfractionation gives a good benefit. Concurrent chemotherapy is giving better benefit than accelerated fractionated radiotherapy, but they still needed to study that how is hyperfractionated as good as concurrent or not. That question is remains to be answered. In India, Dr. Tejpal Gupta also conducted a meta-analysis, and they published in 2015, where they showed that if we look at CTRT, concurrent CTRT and accelerated fractionation radiotherapy, CTRT works better. And actually no form of acceleration, they felt, could compensate fully for the lack of addition of chemotherapy. And the reason why they felt was, and most people by now, their understanding was such that because CTRT really takes care of the nodes very well. That's why, and if the larger the node, the better CTRT would be. So that's why probably CTRT is here to stay. Then people got more excited. Okay, CTRT works better than radiotherapy. We know that. Altered fractionation works better than radiotherapy, standard radiotherapy. We know that. Can we get better than that? Instead of single intensification, can we make it altered fractionation along with chemotherapy? So they compared in the RTOG 0129, altered fractionation with chemotherapy with altered fractionation alone. And what they said was, no, adding chemotherapy, making a double intensification was not working. It did not give better results. But they also said something which was hugely questioned, and that the late toxicity is not increased. The conjecture is that they have passed this statement prematurely, and probably long-term results will tell us different. I raised this point specifically because no story can be complete from my point of view if I do not talk about our experience, in which we also had tried the then standard of care of concomitant boost with weekly cisplatin in 100-odd patients in advanced unresectable cancers of 2000 and 2001. We encountered a lot of mortality, very high toxicity with double intensification, and we did not feel that it can be recommended in a country like ours. We rather take care of nutrition, hydration, take better patients, fitter patients, and remember, this was an era when we were giving conventional only. So we don't know. Maybe IMRT may have a different story to tell, but so far, no. So let's look into good radiotherapy in fitter patients, take care of nutrition and hydration. That was our bottom line. I really want to tell that when we had published this trial, people said, oh my God, so much of toxicity. But when you questioned them across the table, people said they tend to ignore the patients who stop coming. Probably those patients were dying at home and not coming for further radiotherapy. So that is something that we need to look into and talk about it also. Bottom line in fractionation story is that, yes, they are all having some benefit in select situations. At primary, they were good, but not so much at nodes. Altered double intensification, no. And we always must be mindful of the toxicity concern and select our patients well in these trials. Something that I think everybody would want to talk about is the advancement in technology, in modern techniques that we are practicing. But before we go on to techniques like IMRT, I would like to talk about these three landmark. They are not trials, but they are something, publications, which we really need to understand practice before we jump onto the IMRT story. So Gregoire and the teams that he worked with, they went to OTs, they understood because we were moving from 2D era to 3D. We were trying to understand, we were trying to re-educate ourselves, how to practice 3D based radiotherapy. So these groups, they were very passionate and they went into the surgical OTs. They see how the surgeon addressed each level, where they went, so they used the radiological anatomy. They said the mouse was our surgical scalpel or knife. And they started by defining the various levels on CT scan, and so that we could draw and identify these levels. How did that help us? They came up with the first publication came in 2003, where they showed us that different levels, how to delineate, what are the boundaries. How did that help us is that as oncologists, we are supposed to identify the clinical target volumes, which are at high risk, intermediate risk, and low risk. So in the neck, they did it only for the neck levels first. In the neck, we could now identify in the node negative neck, which all levels to be included in the low risk volume, which are at risk for subclinical disease, which might manifest at a later date in future, and leave out the levels which are not likely to harbor subclinical disease. So that was step one. In step two, 3 years later, they published, based again on the same kind of experience, they published their guidelines for us to practice in node positive disease and in post-op neck. They created guidelines for situations that, okay, if the node is positive, how much of level you extend cranially, how much you extend caudally. If the node is sitting at the junction, which part of the level of node becomes high risk and which remains as low risk. So they identified, you can read all this. I'm not going into the detail because of paucity of time also. So they said that, okay, you can look into the high risk, you can define the high risk CTV, you can define the low risk CTV and treat accordingly, because you are ultimately aiming towards intensity modulated radiotherapy. So then there was a long wait, and after a decade, they came up with guidelines regarding how to delineate the primary tumor when you have the best or optimal diagnostic images available to you. Before that, people who were like more conservative, like say for instance us at SGPGI, if there was a base tongue tumor, we would treat the entire anatomical compartment with IMRT, using the entire keeping the entire anatomical compartment as high risk zone. There were others who were younger, more enthusiastic, and they would just draw the GTV and expand the CTV and create a high risk volume by geometric expansion. So there were clearly two schools of thought. So what Gregoire and his team did for us was that they said, see, GTV has highest tumor burden, so that is a part of your high risk zone. A rim around that would have microscopically available cells, tumor cells, which would be in high proportions, but they are not grossly visible. So treat that as high risk zone. And a little beyond that, the peripheral rim beyond that would have some cells of tumor cells. So you could treat that as low risk zone. So they created two risk volumes, CTV volumes for us around the GTV to be drawn. And if you're confident of your baseline diagnostic imaging, you could practice this as 5+5 expansion. So that paved the way for IMRT. IMRT was there and we were all excited. The world was excited. But what has it achieved in head and neck cancers? Well, there is level 1 evidence, PARSPOR trial being one of the primary trials to have shown that actually with IMRT, you do not gain in terms of survival or loco-regional control, but it brings down your morbidity rate, your xerostomia rate. You're able to spare the parotid gland. That is the revolution that it has caused. You're able to spare the parotid gland, and the xerostomia rate would decrease to 1/3 of what a conventional RT patient would experience. And so obviously it would increase the quality of life, better the quality of life. Same was shown by the Tata group in their single center randomized trial, no different, lesser xerostomia was seen. And they even went ahead, Tejpal Gupta gave a meta-analysis and said that there is moderate quality evidence which exists, which says that you will decrease the xerostomia if you use IMRT in your head and neck cancer patients, because you are able to spare parotid gland. The same degree of confidence is not still there for improving disease-related endpoints with the use of IMRT. Very briefly, I'll talk about the palliative treatment in head and neck cancer that has also shown improvement. Lot of very small hypofractionated regimes have come from India, from stalwarts from India, which have given us doable regimes like quad shot or other shot regimes. I'm not going into the detail, but I must mention these and salute these stalwarts. Dr. J.P. Agarwal gave us and his team gave us the 40 gray in 16 fractions regime. Dr. Sushmita came up with quad shot, which was 14 gray in 4 fractions over 2 days. And Dr. Mohanty came up with this elegant regime of 20 gray in 5 fractions. We at SGPGI follow the 20 gray in 5 fractions, highly doable. These are all short, simple, effective regimes which are very effective in tumor control, and they are logistically attractive. Why? If you were to treat a locally advanced cancer which merits palliative, you go ahead and treat by 7 weeks. You will give him toxicity, hospital visits, stay outside home, all those things, logistics, and also yet the tumor control probability will not change. You can treat 7 such patients, give them acceptable toxicity and similar tumor control probability with such regimes. So any of them you can follow at your center, but highly recommended. While radiation oncologists were talking about that, the medical oncologists were looking into metronomic therapy, which means you give low doses of chemotherapy. They are less toxic, but probably efficacious to some extent, at least in palliative cases. Their mechanism of action was different. Tata Hospital has done a randomized trial and has shown that metronomic therapy in the form of methotrexate is actually non-inferior than all your cisplatines and celecoxib in palliative settings, and is also less toxic. So can be considered as an alternative standard of care and very cheap also. Now, if you want, I have 5-7 minutes, or I can stop here with my concluding slides. I leave it.
Kindly continue.
Okay. So why I brought in this targeted therapy was there was a time when people would pick up the phone and ask us, "Ki aap celecoxib nahi, aap cetuximab kyun nahi de rahe? That is also useful. He's an elderly. Please give cetuximab." So there was a lot of hype about cetuximab along with radiotherapy in concurrent setting. This was started with Bonner trial in Alabama in USA. And what they showed was that in 500 odd patients, if you give cetuximab along with radiotherapy, they showed overall survival was better. And the toxicity was limited. There were no mortalities, and it was mainly skin toxicity. It was not mucositis. So they felt that this should be an alternate viable option, especially in patients who are frail, elderly, and so on and so forth. But over a period of time, people criticized them that after all, this is the only trial that has shown benefit. And more importantly, their control arm was radiotherapy alone. by which time in 2005, we were very clear. You can't give radiotherapy alone in a fit young patient. The concurrent CTRT has to be the standard of care. Compare it with that, not with radiotherapy alone. So that was the criticism of Bonner trial. Extreme trial. That was the trial that was conducted in recurrent and metastatic head neck cancers. Okay, instead of giving CTRT, can we, just to consolidate gains further, can we add cetuximab to it? They showed survival benefit of 3 months, but it came at high toxicity, high cost. So it was left to the judgment. Slowly, the targeted agents in head neck cancer, especially cetuximab story, is slowly waned off, if not died off. Now, HPV cancers, how do we address them? Now, this is not our disease, but I just wanted to bring it to notice how the mindset of trialists work. Consistently, these are young males, they have large nodes, small tumors, and they respond very well to chemotherapy. And their results are inevitably much better than the smoking-related cancer. So people in the West said that why not? I mean, why give them toxicity? If we can give similar results, let's de-escalate. Let's bring down the radiotherapy doses. Did not work. So they started a de-escalate trial, which was a multicentric trial where they said, okay, we know from Bonner and everybody that cetuximab toxicity is shade lesser, at least mortality is lesser than cisplatin. So why not compare RT with cetuximab with RT with cisplatin? What did they encounter? They did not encounter decrease in toxicity when they compared, but they encountered decrease in survival. So obviously there was detriment, and they could not recommend de-escalation through this de-escalate trial in head neck cancer patients of HPV positive origin. This is one of my last landmark trials, and actually this is a very important trial. So in Tata Hospital, the story was that there were two schools of thoughts among surgeons. Both were giants in their own right, and one said that, look here, if it is oral cavity cancer, early oral cavity cancer, which is node negative, then if we were to give if we do the primary surgery and there is no node, so just let us wait. When the node appears, we'll do a therapeutic neck dissection. The other school of thought felt, no, why not treat the neck also, address the neck also surgically at the time of primary surgery. And so they said, no, we will go ahead with elective neck dissection. To put to rest this debate in their center or in Mumbai, they came up with this randomized trial, and they provided answer to us. And they said that elective neck dissection, which means that you treat a node negative ipsilateral neck in early oral cancer at the time when you are operating the primary, you will get survival benefit. The other thing that they gave to us was something very important from radiation oncologist point. They gave us the nomogram or algorithm, which brought in depth of invasion also. They said that if lymph node is positive when we do a neck dissection, then please go ahead and give radiotherapy. If lymph node is negative, then what to do? Then look at depth of invasion. If the depth of invasion is more than 10 mm, give radiotherapy to the neck and the primary. If the depth of the invasion is less than 10 mm, then you look at other adverse features and then take a call. It's a value judgment which you may need to do. So this is the last of my slides, which says, to sum up, patient selection is all important. We can never forget patient selection in any trial that we are doing. We have concurrent CTRT. There is a case for altered fractionation scheme. IMRT is here to stay. And of course, we talked about the neck dissection. But I would, from little experience that I have gained over a period of time, I would say that we as radiation oncologists should focus on radiation-related research. There is a lot of scope of improvement. and there is no substitute for good radiotherapy. That is what we really need to work upon. And I would say, as from my perspective, when I'm reaching the other end of the spectrum, that future will probably be more personalized and more individualized than what it is today in radiotherapy in head and neck cancers. Lastly, I would like to say that there is always hope in every nook and corner, and we need to find local solutions. Thank you very much for your kind attentions, and I'm willing to take any questions.
Thank you, ma'am. And I think you have, from over 100 of important trial in the head and neck cancer, you very nicely covered the important landmark trial over in 1 hour. That is amazing. I wondering too many trials in head and neck cancer. 1 hour would be shorter, but you nicely covered. There are few questions, ma'am. As per RTC and RTOG, the margin positivity and extra nodal extension is a standard indication for concurrent CTRT. What are the other indicator where we can use concurrent CTRT in post-op setting? Whatsoever we call soft indicator.
Yes. So all the rest individually fall into intermediate risk category. So they are like, you look at LVI, you look at PNI, lymphovascular invasion, perineural invasion. You look at the multiple nodes and multiple nodes which are present at different levels, especially lower levels. And then you look at, so I talked about positive margin, but there's something called close margin. Positive margin is a high risk situation, but close margin is a intermediate risk. Be careful. That is what they say. So give radiotherapy, because surgeon has not been able to give you a clear margin. So that is what, that's one thing. The other thing is that if there is one intermediate risk adverse prognostic factor, you are safe in one or maybe two. But if there are multiple of such prognostic factors present, then you as a treating physician can take a call and think of adding chemotherapy to post-op radiotherapy, provided the patient is able to withstand that radiotherapy, chemoradiotherapy. And also remember that what we see is the early toxicity. Then the patient goes back home. Something is happening even at 5 years and 10 years, which all the trialists they've lost interest. But something happens, and from radiation point of view, that becomes important.
Mostly sometimes we encounter the extra nodal extension is not present, but we see the PNI skip nodal level at level 3, level 4. Then and in a young age patient, then we think it is the important soft indicator where we can think a patient is young, can tolerate CTRT, there we can think for the CTRT. The other is the altered fractionation is having a lot of question, and I think but less practice, maybe because of their issues with altered fractionation toxicity. And though the trials is saying there is no toxicity, but as you from the trial from the SCPGI, it has shown it is more toxic and those. So can we think altered fractionation in a patient who can't afford having a limited affordability? We have to treat with RT alone. We not that patient not able to afford concurrent chemotherapy. In those cases, we can give concomitant boost because its trials have shown similar OS and local control with CTRT.
So I think you've just hit upon the right group, where we as radiation oncologists should look into it. Dr. Verma, because that's exactly the group. If the patient either cannot afford or for some reason chemotherapy is not possible because of kidney concerns or whatever, and so you would want to give them, and very elegant protocols exist, but the most my personal choice is towards the 6 fractions a week because it's so doable, it's so understandable, and आप Monday to Saturday वैसे भी करते हो इनको ऐसे patient को you can take up for a Saturday treatment, complete it in 6 weeks, you'll get very good result. The only thing in this is be careful कि अगर उस जितने नोड बढ़ते जाएंगे उतना मतलब प्राइमरी विल रियली डू गुड, बट जितना नोड का साइज नोड के बर्डन बढ़ेगा, दैट्स वेयर कीमोथेरेपी हैज एन एज ओवर these altered fractionation. That is what I would say. So choose your patients that way then. But yes, there is certainly a case, and I would love to continue with this kind of fractionation in a select patient group.
Yeah. I think there are a lot of questions, but time is short. It is.
I'm so sorry. I tried to complete, and I'm very sorry if I've confused the students more than what they started off. I can always have this class anytime again.
So I would like to invite Professor Shaleen Kumar sir to, sir.
Yes, no story is complete. He is the one who I have to share this with you, that we all, when we were about to write this paper up and all of us were looking in the other direction, but Dr. Shaleen brought it to the to face the world that yes, there is mortality and we must take cognizance of that. Thank you, Shaleen.
Sir, can you share some of your experience, because you have a vast experience in treating head and neck cancer, and you have done a lot of trial for the student. Can you share your experience or some tips which you want to share with the student?
Dr. Arun, thank you.
Yes.
Today and at this time, I only have to say that today has been an exceptional day in the history of this department, and I think even for us in UP and otherwise. The bandwidth that has been shared by Punita, the range, depth, and bandwidth of radiotherapy practice for head and neck that has been shared by her. This presentation is such a useful resource that it deserves to be taken up, spread over 3, 4, 5 sessions in every class. The papers taken out, dissected calmly, and it will give such insights that are amazing. Punita, I can only say thank you, and I can only say this is impressive beyond belief. Not because I have worked with her for 25 years, but because, gentlemen, this resource material condensed in this way, giving absolutely the distilled version of what is coming. But in order to understand that, to dissect the papers, that will be a pleasure. That can be done in small groups, interest groups, outside of morning classes, and our time is running out. So there'll be time for Dr. Verma for what you suggest, but today the stage belongs to Dr. Punita. And
thank you so much.
Sylvie, please continue.
Yeah, sure, Dr. Punita ma'am. It was a wonderful lecture, wonderful, really appreciable. And I think every student will be benefited with this because it was a huge topic and the students are very apprehensive how to take all these trials. But you concluded in a short, in such a simple way that I think they will not forget. Thank you so much once again, ma'am. Thank you, Dr. Arun, for moderation. Thank you, Shaleen sir, for guidance. And I would like to thank Dr. Ashutosh Mukherjee and Dr. Rashi Agrawal, who are our course coordinator. And thank you, RPG Life Sciences, for giving this platform. Thank you, all the participants. Thanks once again.
Thank you.